My topic is what's new in macular degeneration. I'll divide this into two parts. One will be what's new in wet disease, and then secondly, what's new in dry disease. My disclosures are listed on this slide. So let's start off with wet disease. We've heard already from a number of speakers the issue of submacular surgery, translocation, laser, and of course, in the States, we have approval of pegdaptanab, ranibizumab, bevacizumab, and aflibercept, all anti-VEGF therapies for treatment of AMD. Going back historically, laser as part of the macular photocatalysis study was beneficial, but it's a quite destructive treatment rarely employed today. PDT came along in the year 2000, and it's rarely employed today except in some special cases like retinal angiomatous proliferation and or polypoidal choroidopathy. Submacular surgery, as Dr. Takahashi has just mentioned, is a viable alternative, yet a big study called the submacular surgery trial really showed minimal visual benefit unless the patients had markedly limited visual function. The problem historically is that you can remove the hemorrhage quite nicely, but oftentimes you take along the choriocapillaris and therefore end up with a defect like you see on the slide here, where there's an absence of central pigmentation. For a while we tried to translocate the retina. This was popularized by Jean Dewan. This is really no longer done anymore. We tried to rotate the center of the macula into a healthier area of pigment. It worked in very select situations, but really wasn't the answer. So today we're left with primarily pharmacologic intervention in the form of ranibizumab, bevacizumab, and or aflibercept. We all recognize it's monthly to every other month therapy, but for the most part, patients do very well. But there still are some key questions. What's the best therapy? Of course, we don't have the answer, but we have those three options, and of course, many things coming forth in the future. What's the optimal treatment and follow-up regimen? Well, most times, of course, we inject the patient at baseline. Generally treat for 3 injections spaced a month apart and then go into either a lessened frequency or stop the patient entirely. But what's the best regimen? Not entirely known. Is the best endpoint a totally dry OCT? Well, we're learning that that oftentimes leads to a higher chance of pigment atrophy, and therefore having a bit of fluid left behind may not be a bad scenario. Most times we do employ a monotherapy. Combination therapy was tried in the past, was not that beneficial. Then we have to ask the question, what's the best value treatment? Of course, if you're talking about dollars alone, of course, bevacizumab used off-label is the cheapest treatment. Once again, historically, combination therapy was tried with steroids, PDT, anti-VEGF, but it really did not lead to any better outcomes than with monotherapy alone. So combination therapy, for the most part, is not employed. We've had a number of comparative trials. The two top ones, the CAT trial and IVAN trial, have gotten the most attention. The CAT trial, of course, released 2-year data showing that in a head-to-head comparison, ranibizumab and bevacizumab, whether it's with a fixed or a PRN dosing scheme, can lead to comparably good visual outcomes. Retreatment criteria were a bit more rigorous in this trial in that if there was any change on OCT or change in vision, patients could be retreated. The average patient in the PRN arms required 7 injections on an annual basis. The IVAN trial was conducted in Great Britain, had comparable efficacy, showing that both ranibizumab and bevacizumab are comparably effective. This study also looked at systemic safety concerns and found no concerns between ranibizumab and bevacizumab. When they combined the CAT and IVAN data, once again, the drugs were found to be comparably effective. 2-year data was released 2 years ago, and once again, no surprises there. So Regeneron followed, of course, with their aflibercept, and once again, a lessened frequency of treatment. It can be employed as infrequently as every 2 months after a loading dose of 3 injections, and they found that in a non-inferiority trial, this drug was comparably effective to ranibizumab and bevacizumab. So once again, we have those 3 main entities, bevacizumab, ranibizumab, and aflibercept. Now, the Genentech group undertook an important trial called the Harbor trial, looking at an alternate and a higher dosing regimen. They employed up to a 2 milligram arm of ranibizumab, but found there was no added benefit compared to 0.5 milligrams. But they found that in the alternate dosing regimen, once again, if you follow your patients carefully, this requires a monthly follow-up. Patients can do comparably well to a fixed monthly dosing regimen. This slide here was published by the Harbor Group, but showing very nicely if you follow your patients carefully, whether you use the criteria of the Anchor, Marina, Harbor, CAT, Ivan, VIEW trials, most patients can achieve a couple of lines, about 8 to 10 letters of vision at the 2-year follow-up time frame. So once again, results can be obtained quite nicely with an alternate dosing scheme as defined by the Harbor trial. That's the proven treatment. What about experimental treatments coming forth in the realm of wet AMD? This slide has numerous options. We'll talk about a couple of them in particular. That of the platelet-derived growth factor, which has quite a bit of momentum as far as treatment applicability, and just recognize there's other anti-inflammatory agents as well. So will there be better treatments in the future? Well, we certainly hope so, although of course we have quite nice treatments already. We'll talk briefly about the platelet-derived growth factors along with better means of delivering drug into the eye with existing therapies. An alternative anti-VEGF agent, the ESBA-1008, is a small single-chain antibody in the VEGF inhibitor category, binds very readily to VEGF-A. It blocks receptors of the VEGF R1 and R2 receptors in endothelial cells, and once again is being studied right now in the Osprey study sponsored by Elcon. We don't yet have data from this trial, but once again it's an alternative anti-VEGF agent. We also have a VEGF decoy receptor fusion protein comparable to VEGF trap or aflibercept. This product, Combercept, has been studied and approved in China alone. This, once again, is potentially very effective. Will this ever make it into the States or other countries? Not yet known, but just recognize that Combercept is comparable to VEGF trap and approved for use in China. A lot of interest right now in platelet-derived growth factors. A Fovista study sponsored by Ophthatech. This is looking at the issue of oftentimes we have persistent fluid, we have some fibrous proliferation. This attacks the pericytes and is used in combination with anti-VEGF therapy in an attempt to limit the amount of scarring associated with residual treatment from VEGF, anti-VEGF therapy. So the Fovista studies have completed phase 2 trials. The data has been very sound at all endpoints. There's not only suppression of the neovascularization, but also visual gain. Biomarkers are confirmatory, and this is undergoing phase 3 trials right now. Recognize this would be a treatment in addition to anti-VEGF therapy. This is not a single solitary treatment, but done in conjunction with one of the anti-VEGF agents. We're also always looking for better means to deliver agents into the eye. The DARPin group is a unique molecular protein which can have a higher target binding affinity than antibodies or antibody fragments. This has been looked at in an AMD study. Phase 1 and 2 trials have been done in the realm of macular degeneration with phase 3 trials ongoing. This AGN-150998 product binds with high affinity to all isoforms of VEGF-A. It's a very small molecule, 34 kilodaltons, even smaller than ranibizumab, and binds 40 times greater to ranibizumab. So this has been looked at in a phase 2 trial called a REACH study for macular degeneration, comparing it to ranibizumab. So once again, an ongoing trial. Gene therapy to deliver agents into the eye has been very exciting. This does not come risk-free. Avalanche Biotech has been the leader in this point. They're looking at new vectors to put into the eye. Commonly, it's an adenovirus. There have been some concerns following their phase 1 and phase 2 trials, so recognize that this is ongoing, the research, and may offer a means of better delivery of agents into the eye in the future, but some problems have to be worked out. We've had the use of radiation in a number of trials. Orion has been the most recent. A study done in Europe, performed in 2013, did show that perhaps you can diminish the need for anti-VEGF therapy with robotic-induced or robotic-delivered external beam treatment. Once again, this is certainly far from the method of treatment in most patients today, but has been released in Europe. So talked about drug delivery. Once again, we can look at our existing products, try to get them into the eye much better. We can enhance topically. You're going to hear later about suprachoroidal delivery per Dr. El Reyes from Egypt. Transscleral can be utilized, even intrascleral microneedles. You can use pumps around the eye. You can do gels that you put inside the eye that convert into a delivered product inside the eye. And of course, there's encapsulated cell technology as well. Jennifer Kang Mieler, my wife, is looking at this thermoreversible hydrogel concept It's a liquid at room temperature, converted into a gel, delivers drug inside the eye, and has efficacy now in the laboratory for up to 6 months. Paper being published very shortly in Investigative Ophthalmology, a very exciting area. Neurotech has this encapsulated cell technology device. It's a protein that can be released from this device for a number of months and years. This has been a study that's been passed along to a number of companies. I think that it's still ongoing, but the bottom line is we don't have any definitive data or proof of benefit thus far from this encapsulated cell technology. So to summarize what's new in the realm of wet AMD, monotherapy with ranibizumab, bevacizumab, and/or aflibercept offer the best visual and anatomic outcomes. The ongoing issue of which is best, we compared the CAT-IVAN trials comparing ranibizumab and bevacizumab, comparably effective. Aflibercept, of course, came along. That can be delivered a little bit less frequently. Conbercept has been utilized in China alone, but it has not been released beyond the bounds of China. Anti-platelet-derived growth factors, exciting, trying to limit the amount of fibrotic proliferation, perhaps lead to better visual outcomes. Undergoing a phase 3 trial right now. This would be used in combination with the anti-VEGF therapy. Additional things in the future, of course, we mentioned a number of products coming forth, but at the present time, it really comes down to monotherapy with one of the anti-VEGF agents. Just briefly, my last couple of minutes, what's new in the realm of dry AMD? We've heard already today the issue of AREDS, AREDS2. That is really the only treatment of proven efficacy in trying to limit the risk of progression of the dry forms of AMD. The role of genetics is still controversial. When do you test? What do the test results mean? But there are a number of markers that may potentially indicate a response or a better response to the antioxidants and/or zinc that we've heard about for Dr. Goldbaum this morning. Modifying your lifestyle is always a good thing, of course, but many times our patients aren't quite willing to do that. So what's available thus far? Once again, we heard earlier, AREDS, AREDS2, micronutrient supplementation in terms of lessening the risk of progression. There's a whole array of emerging treatment strategies trying to decrease the progression of dry geographic atrophy. This list actually gets shorter every year because a lot of these products are tried. Either they lose funding or they're not efficacious. But we'll talk about just a couple of things here very shortly. You also can neuroprotect. You can modify the visual cycle. You can reduce the amount of metabolic toxic metabolites, prevent oxidative damage, or suppress inflammation. So just two quick words about lampalizumab, a product by Roche Genentech. It's an antigen-binding fragment of a monoclonal antibody, and the intent here, once again, is to diminish the rate of progression of geographic atrophy. This has been shown in the Mahalo trial to slow down the rate of progression by roughly 20%. You can't really use visual acuity as an endpoint here. It has to be the progression of AMD, the lack of progression of the atrophy, either documented photographically or with fundus autofluorescence. Emixustat hydrochloride, I serve as the chief data safety monitoring individual for this company. The phase 3 trial has been fully enrolled. I can't give any results up. I can just say that the product appears to be safe, recognizing that patients will experience at least a temporary decrease in low luminance visual function. We should have some data next year on the results of Emixustat for the treatment of dry AMD. We, of course, have RP transplantation, stem cell therapy. Recognized in the States, many of you may have heard about the fact there are some toxic cases of patients receiving stem cells, embryonic stem cells in the vitreous cavity. Not a good idea unless you're doing this in a clinical trial. Gene therapy is ongoing, and of course we have the Argus-2 device, which is used right now for retinitis pigmentosa and not yet in the realm of end-stage macular degeneration. So to summarize, dry AMD, AREDS 1 and 2 are the only proven treatments, that of micronutrient supplementation. A number of studies looking at visual cycle modulators, neuroprotective agents, agents trying to diminish the rate of progression of dry AMD are being studied, with lampalizumab being one of the leading contenders and Emixustat being the things that you probably will hear about most recently coming forth as potential means of slowing down the rate of loss of pigmentation. I want to invite you to hopefully come to Las Vegas this November for the American Academy of Ophthalmology, both the subspecialty days as well as the program itself. And I want to thank you once again for allowing me to partake in this great conference. Thank you.